when you do a test, don't forget that what you're doing is simply a test. It's like when you go to have your annual physical. You're having a test. Okay? The results, if they are good, everybody's going to be very happy. If they are not good, we simply know that we have to do something. Okay? And we have to try that the results are as accurate as possible, that they represent your real situation. Okay? Because let's say you study an entire week for an exam, and you answer, and then you start changing answers. And you get 60%. Because you changed 10 answers. Now we don't know, okay, what the problem is. If you didn't study, if you study the wrong things, or if you simply need to know how to behave or approach exams. Okay, so unless, when you choose an answer, unless you see an angel with a fire and a sword that tells you, no, it's not B, it's C, don't change the answer. And if you see the angel, tell me. I know a good psychiatrist. Okay, don't change answers. There is no reason for that. Okay, I know how important grades are. I know how exciting it is to get an A. I know that they are very helpful for scholarships and many other stuff. Okay, but they don't represent how much you know. Okay, they don't tell us exactly what is in your mind. Okay, so work for that. Okay, to try to keep that in your mind. Without, I don't mean that you don't take care of the grades. Okay, but the focus has to be learning, not the exam itself. So we were here talking about the different types of regulation of hormone release. We were talking about the 3 types. Okay, the neural, remember what I told you about the approach to study things like this. Start with the simplest one and then compare. Okay, the neural regulation is simply when we activate the adrenal medulla to produce epinephrine, situations of stress. Okay, we have the humoral in the center. We are detecting the composition of the blood. For example, the amount of glucose, the amount of calcium, phosphate, okay, to release either insulin, glucagon, parathyroid hormone, calcitonin. And then we have the more complex one, that is the hormonal regulation. We produce hypothalamic hormones that will, okay, activate or induce the release of a pituitary hormone that in turn will stimulate the release of hormones in the thyroid gonads or adrenal cortex. Okay, those hormones from the pituitary that act on another endocrine gland to stimulate the release of another hormone are called tropic hormones. Okay, for example, we have the gonadotropins, FSH-LH, okay? And there are hormones from the anterior pituitary that don't stimulate the release of any other hormone. Okay, these are non-tropic. For example, prolactin, that stimulates the breasts to produce milk. Okay, so those are concepts. And when you study, please just make sure you know the concept and know examples of those. Now, the regulation of the endocrine system or endocrine regulation, okay, is not only how much hormone we make, how much hormone circulates in the blood. Okay, there are also regulation at the cellular level, regulation systems at the cellular level. Okay, blood concentration of the hormone is 1, and that is very important because if the target tissues don't receive hormone, they don't have anything to do. Okay, they have to receive an adequate amount of the hormone, not too much, not too little. Okay, that is something that the cells do, and is that they change the amount of receptors that they express in the cell membrane. Okay, that is a concept that is also important to know. Even though you may not be asked that directly, it's important to know what is expression of receptors. For example, let me give you one example that is more pharmacology related. Let's say you have a patient that has elevated cholesterol. elevated LDL cholesterol. And you tell the patient, well, you have to exercise more, you have to change your diet, eat more vegetables, less red meat, less fat. And the patient comes 3 months later, LDL cholesterol is, what are you doing? I became a vegan, and I'm going to the gym 2 hours per day, and the LDL, we need to do something. Okay? And for that, you need to know something about biochemistry and physiology. Okay? What is the function of cholesterol in the liver? Who knows what the liver does with cholesterol?
Synthesizes carbohydrates. It
The liver?
synthesizes like proteins.
Yeah, but
Oh, bilirubin? No, sorry, not bilirubin, my bad. Bile salts.
bile.
Sorry.
The function of the liver is to make bile. Okay, the liver is gonna use cholesterol to make bile. That is what the liver does. That's the main function of the liver.
That's why people with cholecystectomies have decreased levels of cholesterol in the blood because they're releasing more bile, so the body utilizes more cholesterol.
Could be one of the reasons. And the liver cells normally they make cholesterol. Okay, they are able to produce cholesterol to make the bile. While they are making the cholesterol and making bile, they don't have any need. It's like you have a printer at home that you print money. Do you need to go to work?
No.
No, I can print it home. Now, if I break that printer, you have to go to work. So what we do with statins that we give to the patients is block the chain of production of cholesterol inside the cells. We block an enzyme that is key for cholesterol synthesis. Now, liver cells say, my printer is broken. They have to open doors in the cell membrane to get cholesterol from the blood. How they open doors? They insert LDL receptors in the cell membrane and get LDL cholesterol from the blood to make the bile. And that way we get to reduce the LDL cholesterol in the patient by forcing the liver to go to work. Okay, don't print more money. Go and work. That's what we do. And this number of receptors can be down-regulated, can be up-regulated. That simply means express more, express less. Okay, if you start bombarding the cells with a chemical, say I start taking amphetamines, my neurons are going to get upset, and they're going to reduce the number of receptors for dopamine or for any of the neurotransmitters that are activated. Okay, during this, same happens with coffee. Okay, every day we need more coffee and stronger coffee. And let me buy the darker one, the strongest one, put me more, okay? And another mechanism is, well, the contrary would happen if I don't provide enough to the cells for them to work. That would be the upregulation, like in the case of cholesterol receptors. Then there can be also alteration in the sensitivity of the receptors. Okay, cells, at least not clinically importantly, they don't alter themselves, the sensitivity, but the sensitivity can be altered by diseases, for example. For example, inflammation. If you have a receptor that should bind insulin, but also you have an inflammatory process with interleukin 6, interleukin 1, tumor necrosis factor, interferon, that's going to be the same. You know, it's like the lock in your house is dirty. There's mold, there are stones. It's not going to be the same affinity of the receptor for insulin. And that can create situations like what we call resistance to the action of insulin. Because you need now more insulin to get the same effect, because the receptors have lower sensitivity to insulin. Now, there are other local ways of regulating, and we can cite the example of the activation or inactivation of hormones. When we produce thyroid hormone, for example, we produce mostly T4. T4 is simply a tyrosine molecule with 4 iodines. Okay, that T4 travels in the blood. Okay, has a transporter. Okay, and we are going to produce some T3, very little. T3 is the active form of the hormone. Now, some cells are working a lot, some cells are not working. The cells that are working and need to work are going to catch the T4 from the blood, and when the T4 is inside the cells, they are going to remove one iodine. And now they have T3. That is activation of the hormone. Okay? The cells that need will decide if they are going to activate the thyroid hormone by converting it from T4 to T3. Now, sometimes, for example, during disease, or when we are doing a diet for a long time, let's say we are doing a diet for 6 months, hypocaloric diet, we are starving, and the body feels, oh my goodness, this is not good, I don't have food, I don't have energy. Okay, when the cells receive that T4, instead of removing this iodine from here, they remove that iodine from there. Now you have T3 as well, but this T3, in which you remove the wrong iodine, is inactive, doesn't work. It's like breaking the hormone. And that is what we call reverse T3. You can see there, RT3.
It's like an isotope.
It's like, yeah, removing the other iodine, not the right iodine. Okay, that's something that you will see the applications later in pathophysiology. There are other things that we need to know about the regulation. Some hormones have a permissive effect. Okay, permissive effect simply means that for a hormone to act, another hormone has to be present. Okay, one or the best example is thyroid hormone. And why that is important? Sometimes, for example, you may have a kid that is not growing properly. Oh my goodness, maybe it doesn't have enough growth hormone. Let me test. For growth hormone, insulin like growth factor 1, growth hormone is normal. Well, the problem is that for growth hormone to act on the bones, tendons, ligaments, growth plate, thyroid hormone has to be there. Nobody knows well why. That's why we call it permissive. Has to be there. In the case of the heart, thyroid hormone increases the number of receptors and the sensitivity of the receptors for catecholamines, for epinephrine. That's why people, for example, when you study the actions of thyroid hormone, you never see thyroid hormone increases the heart rate. How come? It doesn't increase the heart rate. But thyroid hormone increases the number of receptors for epinephrine in the heart. So now, every time we have epinephrine surge, the heart will respond with tachycardia. It's not because of the effect of thyroid hormone, it's because thyroid hormone increases the sensitivity of the sinoatrial node to epinephrine, norepinephrine. And that's why the same rationale, that's why people with hypothyroidism typically have bradycardia, because since they don't have thyroid hormone in enough amount, they have a very low amount of receptors for epinephrine. So heart is going to be always slow. Okay, and also, for example, thyroid hormone increases the number of receptors for LDL in the liver. People with hyperthyroidism typically have low cholesterol. And people with hypothyroidism have high cholesterol. And what is the importance of that? It is very easy. We are in an urgent care, in a family medicine clinic, and we have a patient, annual physical, or your LDL cholesterol is high. You have to start taking statins. Wait, 1 second. What if the problem is not that the liver has a printer for money? What if the problem is that the liver doesn't have the normal amount of receptors that the average person has? Let me test for TSH. Okay. How is TSH? It's elevated. Oh my goodness, this person has a hypothyroidism. That may explain the high cholesterol. So before giving statins, I'm going to give you thyroxine. I'm going to take the thyroid hormone levels to normal, and then I'm going to retest for cholesterol. Oh, now it's okay. You don't need statins. What you needed was to stabilize the thyroid function. And that's the reason why you're going to see many more examples of the utility of TSH, T4, T3, reverse T3. And even some people say that we should consider TSH as one of the vital signs. Imagine, up to what point? And we should do TSH to everybody. Because correcting that And it's very easy and very cheap, prevents you from using inadequate medication.
What if your TSH is elevated, right? But your T3 and T4 are normal?
Well, those are things that we are going to see in pathophysiology. Okay, the euthyroid patient, the subclinical.
Would you diagnose the patient with hyperthyroidism if the T3 and T4 is normal?
That would be subclinical hypo, but we're not going to enter there.
Okay.
Okay, that is for, remember the objectives is learn how hormones are regulated.
Okay.
That's pathophysiology.
Okay.
Okay?
Professor,
Yes.
How can you differentiate instead of treating the patient first with thyroxine instead of giving like an iodine supplement? Maybe there's a deficit.
We don't give iodine supplements.
No?
Here in the United States.
There's no, but if the patient has an iodine deficiency, can you
Here in the
give
United States. Patient recently came from somewhere.
the Himalayan? The Himalayan. Okay.
From somewhere, and you determine the problem is iodine deficiency. But that is pathophysiology. Let's not enter in the branches, okay? Because that is like extensive.
So if I hope they need to hypercholesterolemia, so hyper will lead to hypo.
Normal cholesterol. We'll have normal cholesterol, typically. Now, we have another concept there that notice that can be confusing at the time of an exam. Okay, and this is the synergistic effect. In this case, 2 hormones, or 3 hormones, or 4 hormones, doesn't matter the number, okay, will amplify, okay, the effects of another hormone. Okay, the effect, let's take examples of, there you have the example of FSH estrogen, and let's use one that is more, that is easier, more simple to understand. How many hormones we have to lower the blood sugar levels in the body? How many hormones you know that lower the sugar levels? You know one that I don't know. I only know insulin. Okay? How many hormones we have to increase the blood sugar levels? Glucagon, what else?
Epinephrine,
Epinephrine,
norepinephrine, growth hormone,
cortisol.
cortisol. There is at least one more. Growth hormone. Okay? 4. Why do you think that is? Why do you think is that?
because hypoglycemia is more dangerous than hyperglycemia.
Why is more dangerous?
You could die. You can
You
go
could
into
die of
coma,
either or.
But it's faster.
Ah, because from the normal glucose level, let's say 70, to death, that is just a distance of 30 or 40. From the normal sugar level, 70, to death, you can feel like 1,000. Okay, so hyperglycemia is not so dangerous as hypoglycemia. We have 4 hormones. Okay, and what the synergistic means, let's say, and this is not the real thing, but let's say that each of the hormones can increase the blood sugar levels in 10 milligrams. So if you use one hormone, let's say glucagon, the blood sugar levels are going to increase from, let's say, 60 to 70. If you use another, the same. Now, if you use 2 hormones, or you increase 2 of these hormones, the blood sugar levels are not going to increase 20. They are going to increase 200. And if you use 3, now they are going to increase 300 or 3,000 times. Okay, the effect of the addition of the 2 hormones, okay, is not going to be like the sum of the effects of the individual hormones. Okay, so they are going to potentiate each other, and we are going to have an amplification of the effect. And we are going to increase the blood sugar levels very fast. Okay, when we are in a real emergency, hypoglycemia, all these hormones are going to increase at the same time. Glucagon, epinephrine, okay, cortisol. Now, glucagon, epinephrine have a very short half-life, so they're going to be destroyed immediately. Cortisol is going to stay there for a longer time until everything is resolved. And then the antagonistic effect is easy to understand. No? Hormones that oppose each other, glucagon and insulin. Okay, even the action of glucagon, epinephrine is too powerful. We have a very high sugar now, insulin has to come to correct the system. Okay, same happens with, for example, aldosterone and atrial natriuretic peptide. They are opposing hormones. If we have hypotension, we have hypovolemia, okay, there will be a signal to the adrenal cortex to produce aldosterone that will retain sodium and water, increasing the blood volume. But if we have too much, now the heart is going to fill that excess fluid. Okay, volume overload stretching too much the heart cavities. Now the heart is going to produce atrial natriuretic peptide. That is a diuretic. Okay, if you analyze the word natriuretic, has Na, which is sodium, and has uretic, diuretic. Sodium in Latin is natrium. It's a natriuretic, urinates sodium. And that sodium goes away with water. Okay, so it's the contrary of the action of aldosterone. It's opposing, it's antagonistic to the action of aldosterone. The ANP, atrial natriuretic peptide, is one of the hormones that the heart produces. It also makes BNP. That is the one that we use for diagnosis of cardiac disease. Okay, BNP stands for brain natriuretic peptide. And actually it's not made in the brain. You see, remember I told you, we are very respectful of the mistakes that people made years ago. We still call it brain natriuretic peptide. Why it's called BNP? Because it was discovered in the brain. Someone was analyzing brain tissue and discovered the substance. Oh, it's a diuretic. Let's call it BNP, brain natriuretic peptide. And that's the reason for that. And we don't call it ventricle. We could call it VMP, but we call it BNP. This is simply an illustration of this concept of up-regulation, down-regulation of the receptors. You put more, okay, put less. And this is illustrating the synergism. Okay, you have there the comparison using mathematical terms of what we mean by synergism and what we mean by permissiveness. For example, in synergism, okay, you have a combination of hormones, okay, and the effect of that combination is not, for example, if you add the effect 1 plus 2 is not 3, it's more than 3. Okay, so always more than the added effect of each of the hormones. You have in the graph a good representation of the action, the combined action of glucagon and epinephrine, and glucagon, epinephrine, cortisol, okay, compared to the individual hormones. And notice how they represent permissiveness. 2 plus 0. 2 plus 0. What is the meaning of 0? That 0 means that that hormone that has to be present has no actual effect. At least that we know on that action. What I was telling about thyroid hormone. Okay, for growth. We know that insulin, like growth factor 1, growth hormone, stimulates the bones to grow. Thyroid hormone doesn't. But thyroid hormone has to be there. That's why we call it 2 plus 0. The 2 is the effect of growth hormone, and the 0 is the action of thyroid hormone. Doesn't have any action, but has to be. Okay, maybe like, okay, I need to go to shopping, can you go with me? You don't need to spend any money, just, I need someone. Maybe it's that, I don't know. So, maybe in the future, we are going to be teaching something different. Because someone discovers, no, but thyroid hormone actually there does this, and oh, now it has an effect. But right now, we don't know. And it is good when you study, you discover that there is a difference between ignorance and illustrated ignorance. No? Ignorance is when you don't know something. Illustrated ignorance is when you know that nobody else knows, that nobody knows. No? And that you feel happy, at least I'm not the only one who doesn't have explanation for this. Okay, let's have a break now before moving to the other topic. Okay, let's come back at. Okay, let's have 10 minutes, okay? 55, okay? 8:55. Please be here on time. Okay, be here on time so we can move quickly. It could happen during stress. The problem with this hormone, there are hormones that have effects on so many tissues that it's difficult to know exactly what happens in each of these tissues. For sure, according to these laws, some tissues are going to downregulate the receptors. Invasion.
Well, sorry.
Wow. Mostly the red ventricle. I mind that the left ventricle. Okay.
Thank you. And now this one is like the one that I was Oh, that one too. That one I finished with like
And then they did some more freezing and more scratches. So then they let's see, wait until August. Yeah, so the night, so they said we'll wait until August. But he gave me it since he knows the case. It's worse or so far. So right now,
Your family don't have anything like
whatever, but it's getting a bit better. That's good.
Today is going to be difficult. I have two students going 12 to 12:30, 12:30 to 1, and then I have to do with the class of 2020. ACLS. When do you tomorrow? When are you around? Tomorrow. I will be here very early. I get here 6:30. Okay.
Can we do it tomorrow? Early? Where's, I can just ask him where your office is. In the science. Thank you. And then we can go in and
Okay. On the physiology questions in
Because I feel like I did, that's my week.
In the syllabus you have my phone off it, so you can, because normally the cell phone is in do not disturb.
Okay.
So when you're here, call the office.
Yes, okay. Thank you.
Okay, I was about to say, hold on now.
No, pero se puede dormir con el pipino.
Is that congenital or hereditary?
But you notice yesterday you've never seen your pipino before.
Maybe I have. I never paid attention to it. Regular bowel movements, anything wrong with my heart, respiratory,
Don't start exploring your
blood levels are always fine.
You start looking for something that you will take care of that.
I was just weird out, but and we're learning about like
You have any difficulty speaking or swallowing or eating? You have any obstruction of the airway?
thank you. I was always worried. I'm like, I got a little chill. Like, thank you.
depolarizing muscle relaxants. Muscle relaxants. Like Sensipone.
Depolarizing.
They stimulate and then depolarize more
They
remedy.
give them in the depolarized state. They don't
By the time
Maybe blocking potassium channels. If you block potassium, you don't produce the depolarization. They stay depolarized.
and non-depolarizing those inhibit the influx of sodium.
continue, please. So, we're going to be talking now about the hypothalamus pituitary axis in plural, because there are several. We have the hypothalamus pituitary thyroid axis. We have the hypothalamus pituitary adrenal axis and hypothalamus pituitary gonadal. Okay, the three of them can be studied at the same time. You just have to change the names of the hormones. You have thyroid releasing, corticotropic releasing, and gonadotropin releasing hormone from the hypothalamus, GnRH, CRH, TRH, and they will stimulate hormones in the pituitary gland. TRH will stimulate TSH, CRH will stimulate ACTH, while GnRH will stimulate FSH and LH. And they in turn will stimulate thyroid hormones, cortisol, and will stimulate testosterone, estradiol from the gonads, depending on what axis we are talking about. And there's going to be a negative feedback, to establish the release of the amount of hormones that is going to be released in the body. Now, there are some little secrets that are important to keep in mind before you enter. So you're going to study your physiology, having in mind always that this is in preparation for pathophysiology and clinical medicine. How we use that. When you're working in a hospital, nobody, next patient sits down, what is the effect of thyroid hormone? No, they don't ask that. They may ask that, but they don't go for that reason. You need to understand what's going on with the patient, interpret the blood test or the diagnostic test, order the tests that you need, and then give the proper treatment. And when I studied all these things many years ago, I studied like everyone else, reading the book, memorizing things, drawing, and having a test. And of course, you believe everything you read in the books, like, okay, it is what it is, no? Someone studied this, discovered this. Then I knew that many of these hypothalamic hormones were hypothetical. Simply, there has to be one. But we haven't discovered it. Why is that? Because we normally, the hypothalamic hormones travel from the hypothalamus to the pituitaries, like going down one floor. They don't go ever to the parking lot, and they are inactivated there. So there is no way that we can detect hypothalamic hormones in the blood. If you want to get a sample of blood with hypothalamic hormones, you have to put a needle, a catheter inside the skull, in the petrosal sinus, and get blood from there. And we don't do that frequently. We're not going to do a research. Let's take 10,000 volunteers and sample the petrosal sinus in all of them. Because who's going to pay for the meningitis, encephalitis, all of the things? No? So many of these hormones were hypothetical, and with the years, they have discovered what those hormones are. We simply call TRH, we call CRH, because it's hypothetical, but now we have discovered that, for example, we are going to take the example of prolactin, because it's the hormone that produces most of the endocrine problems that you are going to find in the primary care. Excess prolactin is something that is extremely common, as a cause of different disorders, and we need to understand how prolactin release is regulated. Everybody has prolactin, men and women. Doesn't matter that you are going to lactate or breastfeed or not. We produce prolactin every day. Prolactin is very important for the immune system to work and has other many functions that we are going to be talking about. When I studied medicine, this is what the books had. Prolactin releasing factor and prolactin inhibiting factor or hormone. You can use hormone or factor. I thought, someone discovered this PIF and this PRF. No, they hadn't discovered it yet. They were hypothetical. Now we know that prolactin inhibiting factor is actually dopamine. Dopamine is like a brake. The hypothalamus produces dopamine to hold the production of prolactin, so we don't produce too much. So having lots of dopamine will stop prolactin from being released. What is prolactin releasing factor? Oh, TRH, thyroid releasing hormone. So if you have a lot of TRH, besides producing TSH and thyroid hormone, you're going to produce prolactin.
Say that one more time, doctor.
If you have more of the releasing, stimulating hormone, you're going to produce more of that hormone. But in this case, since this hormone, besides TSH, stimulates prolactin, also prolactin is going to increase. Now, what will happen, what do you think will happen in a patient with hypothyroidism? Someone who has removed the thyroid gland. What happens to TSH and TRH? You remove the thyroid, what happens with TRH and TSH? We are removing the pituitary. We are removing the thyroid. Remember the negative, what negative feedback means. Okay? You have a hypothalamic hormone that is TRH. We are in a cold place. Oh, we need to produce heat. The brain knows that we need to produce heat. We are going to produce TRH. TRH is going to stimulate TSH from the pituitary. TSH is going to stimulate the thyroid to produce T4. T4 is going to reach the tissues and be converted to T3. I will increase the metabolism and produce heat. Once I have enough thyroid hormone in the circulation, I will make a negative feedback. Now, if I remove this, TSH will say, thyroid gland, please produce thyroid hormone. Thyroid gland, please. No response. Now, I have to start screaming. Okay? Since you don't receive the feedback, you have to talk very loudly to see if there is someone hearing. That's why when you have hypothyroidism, that we call primary removal or dysfunction of the thyroid gland, this is going to be very elevated. And we don't measure that, but we suppose. And it's also very elevated. What is going to happen with the excessive TRH and prolactin? Prolactin is going to be what? Elevated. And you know what is prolactin? This is the previously hypothetical gonadotropin inhibiting factor. So it's going to put a brake on FSH and LH. It's going to stop the action of GnRH. It's going to reduce FSH, LH. What is going to happen in the testes and ovaries? No menses, no ovulation, no testosterone, no androgens, no estradiol, no progesterone. So people start complaining of, I have erectile dysfunction, I feel weak, I don't have I feel bad, I'm sad, I don't have a motivation for anything. Oh, maybe you need Prozac. Prozac doesn't work, amphetamines. Did you test for TSH? Or did you test for, see how TSH is important? Okay, because that gives you an idea that something's wrong. Okay, so hypothyroidism will increase TRH, that will increase prolactin, that will inhibit FSH, that will inhibit sex steroids. That will make people feel miserable, and they don't need a psychiatrist. Okay? Now, dopamine is the one that inhibits prolactin. Now, this patient comes saying, I was taking a test yesterday, and I chose A, and then I saw an angel with fire and a sword that told me it's not B, it's C. And my friend, the psychiatrist, decides to prescribe a medication that blocks dopamine action, like most antipsychotic medications. Okay? We give a medication that will block the receptors for prolactin. So prolactin, the dopamine is not going to be able to bind to the cells to produce prolactin. There is no brake. There is no one outside. Let's escape. Okay, the brake is broken. Now the cells that make prolactin are free to produce all the prolactin they want. And they are going to produce lots of prolactin. They are going to have decreased libido, erectile dysfunction, lack of motivation. Even they may have galactorrhea. In the case of women, they are likely to have galactorrhea, produce milk. That's not common in men. Only 20% of men may have some discharge from their breasts. But women, yeah, like 80% of women, or 60 something or 80 will have galactorrhea as a result of excess prolactin. Okay, those are the things that you need to start to understand about all these processes. So going back to our physiology, okay, there you have the organization of these hypothalamus and pituitary hormone, the relationship between them. The hypothalamus is a tiny, very, very tiny structure. It's like smaller than a quarter. Okay, it's very tiny. But it has so many functions that remembers the liver. Okay, I don't know who has more functions, the liver or the hypothalamus. But if you analyze, compare by size, my goodness, the hypothalamus has nuclei that are like 10 cells. 10 cells governing the body. Okay? Notice how many functions: heart rate, blood pressure, body temperature, sleep cycles, fluid balance, water balance, thirst, appetite, body weight, many more. I didn't want to overwhelm that. Okay, and produces hormones that regulate the pituitary. It's like the bridge, the connection between the central nervous system and the endocrine system. Okay, if we call the pituitary the queen of the endocrine system, the hypothalamus is the king. Okay, it's the one that is over the pituitary. Okay, the hypothalamus produces releasing hormones to turn on the production of some pituitary hormones, anterior pituitary, and inhibiting hormones to turn them off. And you have here some examples. Okay, you have dopamine, which is the previously known as PIH, inhibiting hormone, TRH. They both, stimulate, TRH stimulates, dopamine inhibits prolactin. There are still some people that think that there could be another substance that is another hypothetical PRH, but still doesn't have that. That is a hypothetical name. We know about TRH. Then we have the other red one is somatostatin. Notice that another name for somatostatin is growth hormone inhibiting hormone. Okay, but it inhibits the release of TSH and growth hormone. We have then other releasing hormones: growth hormone releasing hormone, gonadotropin releasing hormone, corticotropic releasing hormone. Those are the ones that stimulate the release of different hormones from the pituitary, anterior pituitary. Okay, and then on the right side, in orange, you have the hormones, okay, that are made in the hypothalamus and stored in the pituitary: antidiuretic and oxytocin. They are very similar, chemically speaking. Okay, they are very, very, it's one atom, but they have different. Okay, antidiuretic and oxytocin. They are stored in the posterior pituitary and released, okay, to perform their actions. Antidiuretic will help retain free water, only water, and oxytocin will promote smooth muscle contraction. Okay, that, for example, in the case of breastfeeding, will produce ejection of milk. Okay, nobody's sure what it does besides that. There is no disease that we know because of lack of oxytocin. Okay, the patient has hypooxytocemia. We don't know that. Okay, we know when oxytocin goes up. Okay, during orgasm, during different situations, and we don't know what happens because people, I don't know, say you reduce oxytocin release, people still have orgasm. Okay, and it's not completely necessary, but we simply know it goes up. Okay, there are many things to investigate, but if they don't represent any disease or any source of, let's see what medication we can make for that. No one is going to give you funds for that research.
Professor, is there such a thing as women with schizophrenia, which is related to dopamine, and having no menses, no sex drive, no nothing?
With the medication, the effect of the medication. Okay, the effect of the medication. You increase prolactin, and that's why, okay, we don't recommend this to anyone, but while a woman is breastfeeding, she's not likely to get pregnant because the prolactin will inhibit ovulation. Okay, so women can be without any possibility of being pregnant. That's not used as a contraceptive method. So if you don't want to have kids, use other methods, not breastfeeding.
Why is it that they say that? I mean, I know that's changed because I've seen other people like not follow that anymore. But I haven't looked into it. That they used to tell women to not breastfeed while they were pregnant.
You can breastfeed while you're pregnant.
You can. You can't.
Milk, the action of prolactin is inhibited by progesterone and estrogen. While being pregnant,
It's so weird because I've seen people
I'm not going to say that there is no a case that, but the action of the progesterone, for example, progesterone is a muscle relaxant. It's going to oppose oxytocin. So the action of oxytocin is not going to occur. Okay? And estrogen prevents the action of prolactin. So while pregnant, breastfeeding, I don't know. Maybe it's possible, but at least not in the majority.
If the woman has had like pregnancies back to back, she will be able
Oh,
to breastfeed.
yeah, because they had like a pregnancy like
Yeah.
right after like not even
Well,
six-
that would be another, if they get pregnant during the breastfeeding,
Yeah.
But,
I mind that.
but it's weird that they get pregnant while the prolactin is elevated.
No, but no, that can't
But they
happen.
can,
Yeah.
they can get,
Remember, it's like if you take the pill, if you forget it one day, you can get pregnant.
I think they got
So if
pregnant
one
like
day,
6 months.
let's say one day you are very excited for something, for some reason, oh, it's my cousin's birthday, I'm happy to see you, dopamine increases, blood prolactin, ovulation. That can happen.
What happened over there?
Yeah. Dopamine, and anything that produces excitement will increase dopamine and will block prolactin.
So guys, if you're very happy, don't try to get pregnant.
Exactly. You have to only get pregnant if you feel sad.
So if you want to get pregnant, get happy.
So there's no way to get pregnant at PA school.
Okay, let's go to ADH. Okay, ADH is a hormone that has several names. Okay, antidiuretic, also vasopressin. Also, you will hear arginine vasopressin. That's AVP. Sometimes you see AVP, which is arginine vasopressin. It's exactly the same thing. Okay, but it's talking about different perspectives of ADH. We are going to be studying this in more detail when we move to the nephrology part to understand the real interactions between the kidney, hypothalamus, the heart, the adrenal cortex, medulla, etc., in the regulation of the body water and electrolytes. The ADH is extremely important in regulating the blood pressure and the blood volume. It also participates in vasoconstriction. That's why it has this other name, or vasopressin. But that occurs when we have a very low blood pressure, that we release it to produce vasoconstriction. Here we have how we regulate the ADH secretion. Okay, we have some osmoreceptors in the hypothalamus, okay, that are going to be activated every time the blood osmolarity increases. Okay, normal blood osmolarity is around 285 milliosmoles. We always use, for mental calculations, we use 300, but the normal is 285. But notice that every time the osmolarity of the blood goes above 280, so a bit below normal, we start making ADH. Let's say we eat something that is very salty, okay, blood osmolarity, or we simply are sleeping 8 hours without drinking water, sweat, and not drinking. The blood osmolarity in the morning is very elevated compared to normal. So osmoreceptors are going to be activated. They are going to send signals to the posterior pituitary to produce ADH. ADH is going to travel in the blood and is going to act on the kidney. And notice what it happens when it reaches the kidney. it is going to bind to receptors, okay, that are present in the collecting duct cells, distal nephron collecting duct, and they are going to induce the expression. Remember what expression means when we were talking about upregulation of receptors? They are going to induce the expression of receptors of aquaporins in the cell membranes of the collecting duct cells. So the water that is trying to escape, okay, through the collecting duct to the bladder is going to be taken back into the kidney by osmosis. How that works, we're going to see this in more detail when we look at the kidney. But if you remember from your previous anatomy studies and physiology studies, you say this is the kidney. We have here the cortex, and we have here the medulla. There you have the glomeruli, okay, efferent arteriole, you have proximal tubule, distal tubule, and then you have the loop of Henle, and then you have the collecting duct. Okay, that is the final part of the nephron that takes the urine to the bladder. You remember the osmolarity of the tissues and the urine and the blood in the cortex compared to the medulla? Remember the osmolarity at this level, how it was?
No, higher is.
Below. You know, the concentration of sodium, urea, etc. Here is around 300, like the plasma. Below here is like 1200. Okay, so when the water is going to be eliminated in the urine, we place some aquaporins in that collecting duct. Since you have a very high concentration of sodium here, very high compared to the one of the fluid that is going down, the water is going to be reabsorbed, going to enter the medulla of the kidney, is going to enter the blood vessels, and it's going to be placed in circulation again. That's the way antidiuretic hormone acts. Okay, so when we need to retain free water, only water, okay, if you need to retain sodium, which is not good when you eat a pepperoni pizza, then you have to use aldosterone. Okay, but that is used when we have hypotension, for example, or we have low sodium in the blood. That's the meaning of this expression of aquaporins, okay, that will start retaining free water because of the osmotic gradient, okay, between the urine and the medulla of the kidney.
Professor, is there, for patients with hypertension, is there any like pathology regarding their ADH and aldosterone?
Aldosterone, yes.
Yeah?
Yeah, no, ADH no. Most cases of what we call primary essential hypertension are because of hyperaldosteronism. Right.
So then, but then technically, wouldn't like ADH compensate for the lack
Yeah.
of? So then,
Yeah. When you have excess volume or excess sodium, ADH retains more water. But let's leave something for pathophysiology,
okay.
because that produces volume overload and blah, 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 and more and more.
Well, then if they hydrate properly, wouldn't they just like wouldn't they?
Let's leave something for education. You don't want to have the 3 semesters in one. Okay, this slide will have the factors that stimulate and inhibit ADH secretion. Okay, the mechanism that you have in the center is more or less the same thing that we explained before. What stimulates ADH? Well, we already mentioned increased osmolality. Okay, then we have a decrease in blood volume, a decrease in blood pressure, angiotensin II. Okay, when we move to cardiovascular, we are going to study that renin, angiotensin, aldosterone system. Angiotensin is a chemical, it's a peptide that has many functions. One of them is stimulate aldosterone release. Another is produce constriction of the efferent arteriole in the kidney. Another is to induce the release of ADH. Another is to stimulate the thirst mechanism. So several actions that we have to have in mind when we prescribe angiotensin converting enzyme inhibitors. We are going to help with the blood pressure. We are going to help save the kidneys, prolong the life of the kidneys, But also we are gonna reduce, okay, the ADH release. We are gonna reduce the thirst mechanism. Okay, we are gonna do several things, which means don't prescribe if there is no need. If the patient needs, of course, they have more benefits than. Now notice what else produces increases ADH. Pain, stress. Just being in a hospital, just being in the emergency room with pain will produce increased ADH, stress, nausea, vomiting. Okay, that is a very common syndrome that occurs in people who are hospitalized, that is SIADH, syndrome of inappropriate ADH release. Why that happens? There are many causes. One of them is pain. Another is stress. So just being in the hospital with pain increases ADH production, they retain water, and the sodium levels may drop. Okay, so we have to, instead of, okay, the patient has hyponatremia, let me put sodium. Wait, maybe it's because of the pain. Give something for the pain. And when the pain goes down, reassess the sodium. Oh, it's normal now. Okay, we don't need sometimes to use medication. Simply let the body work properly by removing symptoms, removing or making the patient feel better, more comfortable. There you have the factors that inhibit ADH release on the right side. Okay, you may mind is the contrary, no? Decrease osmolality, increase blood volume, increase blood pressure, atria and natriuretic peptide, all the things that happen when we have a volume overload or when we have low sodium in the blood, and ethanol, drinking alcohol. So, I don't know why if I just had a shot of whiskey, I've been going to the restroom so frequently. I've been 3 times in the restroom. So now I'm dehydrated, I need more whiskey. No? That's what happens. But there you have that explanation, but you really don't need to enter into more details, okay, about the, except what we have already mentioned. Now, prolactin, we already mentioned that, right? TRH stimulates, dopamine inhibits, okay, and there you have the effects of prolactin, stimulates the breasts to produce milk, has actions in other tissues that sometimes difficult to assess, okay, when you don't have any disease, anything that happens as a result, okay, and there you have the stimulus, okay, another stimulus for prolactin release, suckling. There is another stimulus that is the cry of a baby. It doesn't have to be your baby, it can be any baby. If a woman is during the breastfeeding process, another baby that is crying may stimulate prolactin and oxytocin release, so it's ready to feed the other baby if it's necessary. Something that was very common many centuries ago and millennia ago. Okay, that children, when people lived there, like 2,000 years ago, children were not of a person. Children were of the entire tribe. Okay, we know that came from that uterus, but it's a child of everybody here, and anybody could breastfeed the kid. So there are different hormones necessary for breast development, for lactation, okay, for the development of the changes in the breasts during menstrual cycle and during pregnancy lactation. There is prolactin, growth hormone, cortisol, okay, estrogens. And there you have the explanation of the growth of the glands during pregnancy, prolactin, estrogen, progesterone, and stimulating the gland to grow, preparing the gland for the moment when woman is going to start breastfeeding. Now, during pregnancy, estrogens inhibit, okay, the high estrogens inhibit lactation. Okay, after delivery, okay, there is a sudden decrease in estrogen and progesterone. Once placenta is gone, there is a sudden decrease. Okay, and high prolactin now is free to act and stimulate milk production. Remember, the first days, women don't produce milk. They produce a very clear substance, the colostrum, that is just fluid with tons of proteins, which is extremely important because it's not milk, but has lots of antibodies. And the first antibodies that are going to enter the gastrointestinal tract, okay, to protect children against infection. This will inhibit ovulation, as we mentioned before. There you have the interaction of oxytocin, prolactin, okay, in these processes. You have the effect of suckling, stimulating nerves, okay, stimulating the hypothalamus. Hypothalamus leads to the release of oxytocin, okay, and prolactin. Then oxytocin stimulates contraction, okay, in the lobules. Okay, the lobules of the breasts are surrounded by cells that are epithelial cells, but they have contractile properties. They are called myoepithelial cells. Do you have any question? Any question?
When I was asking that, it says that high levels of prolactin while breastfeeding will not into the ovulation. So, you have a less likely chance of getting pregnant.
Is what?
That you have a less chance of getting pregnant than during that time.
Exactly, like we were saying before. Okay, prolactin, hyperprolactinemia inhibits ovulation. That's why, theoretically, while a woman is breastfeeding, she's not able to get pregnant. But here we have the combination of the two actions, oxytocin and prolactin. Okay, oxytocin produces contraction of these myoepithelial cells, leading to ejection of milk. Oxytocin also acts, for example, during ejaculation. It's the one that increases to produce a contraction of seminal vesicles and lead to ejaculation, and also that role there. Okay, it's a smooth muscle contractor. Progesterone, on the other hand, is a muscle relaxant. Okay, will inhibit the contraction of the smooth muscle. That's the reason why, for example, pregnant women tend to have constipation, because high levels of progesterone inhibit the contractions of the colon. So it's more difficult, okay, the defecation reflex, contraction of the colon for defecation.
You said progesterone?
Progesterone. Well, here we have the regulation of oxytocin. Notice that they are mentioning here, okay, psychogenic stimuli. Okay, oxytocin is produced in the hypothalamus and goes down. Notice that it's traveling down the axons. This is the posterior pituitary neurohypophysis. We mentioned that the first day, that in the hypothalamus you have the cell body of the neurons. Okay, then in the infundibulum we have the axons, and these hormones are stored in the axonal ends in the posterior pituitary. Okay, that's where stored in vesicles. And for example, suckling, cry of a baby, some psychogenic stimuli may either induce or inhibit the release of oxytocin. Okay, someone who is under stress, in a dangerous situation, things like that, okay, that will inhibit all these functions. Here we have more about the actions of oxytocin, because oxytocin also induces contraction of the uterus during delivery. And if you remember, this is one of the few examples of positive feedback that we have in our physiology, at least that we know and are well studied. Okay, we have the action, for example, estrogen. Notice what we call the permissive action of a hormone. Estrogen, during the entire pregnancy, okay, is inducing the expression of oxytocin receptors in the uterus. 9 months. Estrogen, more receptors. So at the end of pregnancy, the uterine cells have tons of receptors for oxytocin. There is a moment when there are changes. Okay, the baby is too big, and the pressure of the head of the baby on the cervix starts producing dilation. Okay, we have other things there. Okay, we have the actions of the prostaglandins that are produced locally that stimulate some uterine contractions. Okay, if someone has delivered before, they know what we are talking about, some smaller, milder contractions that occur before the actual act of delivery. Okay, and then once we have the dilation of the cervix, that will send signals to the hypothalamus for producing oxytocin. Oxytocin will stimulate the uterus to contract. That contraction will push even further the head of the baby, that will produce more dilation of the cervix, more signals will go to the hypothalamus, more oxytocin is going to be produced, and that's what we call positive feedback. Instead of a hormone that is going up, taking it down, we do the contrary. It's going up, we put it further up. And that will end when the baby is outside the uterus. When you don't have any more stretching of the uterus, no more dilation of the cervix, then all this process stops. It's impossible to maintain this positive feedback forever. It's not compatible with life. Another hormone that we need to understand the regulation is growth hormone. Notice that there are many things in common. The only thing that you have to change is the name of the hormone. You have a hypothalamic hormone, a pituitary hormone that will do an action, will stimulate the release of another hormone. In the case of growth hormone, we have a growth hormone releasing hormone, stimulating the release of growth hormone, and we have somatostatin. Another name for growth hormone releasing hormone is somatomedin. And somatomedin is the IGF-1. So forget about that. Growth hormone releasing hormone and somatostatin are the ones that stimulate and inhibit growth hormone. Now, what else can stimulate the release of growth hormone? Notice this hormone here, ghrelin. Who knows what that is? The one that we release when we are hungry.
When we're what?
Hungry. Hungry. And typically it's produced when we have low levels of glucose in the blood, when our stomach is empty. When those conditions are met, sugar is normal to low, stomach is empty. Those conditions have to be together for ghrelin to increase and stimulate the growth hormone, the production of growth hormone, the production of GHRH, and inhibit somatostatin. That's why my grandma would say, children grow when they are sleeping. And she didn't know any of this. But that's true. When we are sleeping, if we sleep enough, because if you wake up at 2 a.m. to eat some candies or some sweets, they're going to cut the growth hormone production. So we have to be fasting, for a while for growth hormone to go out. Now, what growth hormone does, it will act on several tissues: muscle, adipose tissue, bone, liver. But one of the most important actions of growth hormone is stimulate the production of insulin-like growth factor 1. That has an even more powerful action than growth hormone. That hormone is produced mainly in the liver. That will also will make the tissues grow, and is the one that is going to make the negative feedback on the production of growth hormone and the production of GnRH. Notice that growth hormone itself also makes a negative feedback on GnRH. There you have on the left, more things that regulate the production of GnRH, GHRH in the hypothalamus. Presence of amino acids stimulate the hypothalamus to produce growth hormone. And what inhibits growth hormone? Glucose, free fatty acids, that ice cream before going to bed. So have that in mind. In some countries, children don't grow because they don't have food. In some countries, because they have too much food. That's always a problem. Now, the hypothalamus, in response to these signals, also produces somatostatin that will balance, will inhibit the production of growth hormone. There you have growth hormone stimulating the production of insulin-like growth factor 1. That is the one that we call somatomedin. I was saying wrong before. Somatomedin is IGF-1, and that is the one that has the that promotes or performs the actions of growth hormone, which is linear growth in the bone, increased organ size, decreased adiposity, increased lean body mass. It's everything that many people want from going to the gym, no? More muscle, less fat. Now, the problem is that we have this in excess. Not only our muscles are going to grow and our fat tissue is going to shrink, also our heart is going to increase in size, our bones are going to get larger, maybe compressing our nerves, optic nerve, for example. And we don't want that. Okay? Excess of any of these hormones can be dangerous sometimes. Here we have the hormonal regulation of growth, nothing new here. I just wanted to add this slide here, okay, for you to see some of the things that we are going to be studying in pathophysiology. And the reason why we need to know this, and we will study this in more detail in the future, is you will have many patients that will request things. Oh, I need this prescription. Okay, sometimes if a patient comes asking for vitamin C, I will tell them, okay, try not to take it in excess, because you can have, kidney stones, okay, or you're going to have a very expensive urine, because that's simply not necessary. But there are things that hurt people, okay. For example, growth hormone has a very important diabetogenic effect. Remember, it's one of the hormones that increases the blood sugar levels. Low sugar stimulates growth hormone when children are sleeping. Growth hormone will go, okay, to the different tissues, and it's going to make the liver to release glucose into the blood, because we need that glucose in order to, okay, increase the metabolism of the tissues that will grow. But if we are taking exogenous growth hormone for no reason, okay, we are going to have elevated blood sugar levels, and we are going to develop diabetes. And it's one of the manifestations of patients with acromegaly, for example. Okay, that information also helps when you have a patient that simply has high blood sugar levels. The first thing that comes to mind is, are you fasting? Yes. Well, maybe it's diabetes. Maybe it's not. Okay, we have to look for other things. Maybe acromegaly. Okay. The patient with acromegaly is not going to look ever like the pictures you have in the books. Okay? Patients start having mild manifestations. Maybe the only manifestation is fatigue and high blood sugar levels. Maybe 3 years later they develop the classic faces, the appearance of the patient with acromegaly, the enlarged hands and ears and nose, but not. They don't start one day looking like that. You don't wake up and have a coconut tree in your yard. Oh my goodness, suddenly there. Okay, that happens slowly, and we need to detect it before it actually develops, okay, into a manifest disease.
Professor, what would be the reasoning why they were saying that growth hormone could be used as an anti-aging?
Anti-aging?
Yeah.
I've heard for
Because I don't.
bodybuilders or increase muscle mass and decrease adipose tissues. But anti-aging?
I heard, but I'm thinking and I don't see.
No, not that I know. I would never play with hormones. Remember, there are many of these hormones that are hypothetical still. So we don't know how these hormones will affect the other hypothetical ones. There are many things that we don't know about endocrinology that we will know one day. Unfortunately, many times after people have been taking something for a long time, and they start having some stuff. Because you're not going to do, let's do an experiment. Let's take 10,000 people and divide in 2 groups, randomized trial. You're going to get this hormone and you're going to get placebo. You don't do that. What are you looking for? Okay. And then the research is observation. Okay, now they're taking Ozempic. Are people counting how many people wear blah, 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 blah. Okay, income, race, age, education, blah, 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 comparing. And maybe in 5 years, they publish a study. We realize that Ozempic produces this and this and that out of the market.
But I heard that with Ozempic, people use it to lose weight, but actually it's reducing the muscle mass and not the fat. So you're actually getting fatter.
No, man.
It reduces.
No, but the only thing that I see with that is any method that doesn't teach you how to eat and how to change your, is gonna be a waste of time and money.
And
And
the
how-
thing is that, like, insurance companies require that the patient has tried at least 3 months of dieting before they're approved to take Ozempic or what's the other one called?
I can say so.
But what
can
the
say so.
doctors say, exactly, the doctor say, oh, have you been trying for like at least 3 months? And they're like, I mean,
Yes.
yeah, sure.
You know
So
that-
then,
there
as
are-
long as you document it,
You know
they
that there
approve
are
it.
people who apply to Miami-Dade College, get the financial aid and leave and never present here. That happens. There is people for everything. And then they go apply, maybe they move to another state or another city and they apply to another college, get financial aid. That happens. And create, or against identity theft. What would I do with my niece identity when she, let's say she's 15? What would I do with that identity? Apply for a loan for a house? No. But I can apply for, like I said, I work for Miami College, financial aid. I'm gonna take 100 credits this semester. And then disappear. Who knows? We can be.
Yeah, and then you have like the shortage, national shortage, because people are getting Ozempic to lose weight, and then diabetic patients that actually need it.
But I don't want to be in the first line. Because these people who are taking Ozempic now, these are experts. These are in the experimental, the phase 3 clinical trial. They are volunteers for that, and they are paying for participating in research.
Wasn't there problems with kidneys?
Which one?
They said that there was a kidney that I can't kidney failure.
Ozempic.
Same thing. They do this one at the same time.
But
But they say it's a small
no.
percentage.
Anybody can have kidney failure taking or not taking. No, the fact that you were taking Ozempic and had kidney failure doesn't mean that Ozempic. Okay, the roaster doesn't make the sun go up. Two things happen at the same time or one after the other doesn't mean that one is the cause of another.
Yeah.
Okay, that's
That's what they were saying was like one of the only effects that is possible from when they were doing their trials.
of course it's possible, but right now I'm sure there is no data for that.
Not yet.
Like, I remember when COVID, the vaccines. My niece, it was like 5, and my sister didn't want to vaccinate. No, because I've heard that girls are getting sterile with the vaccine. How many girls you know that have tried to get pregnant after the vaccine? I don't know any. I don't know any small girl that tried to get pregnant and couldn't, because of the vaccine. How's that? How you have a vaccine that has been administered for a month and you know that it produces sterility? Where do you get that data from? Someone? Okay, let's finish with this slide here. And here we have the last of the hypothalamus pituitary axis. This is the gonadal. Notice that it's very similar. Now the only thing we have to do is change the names. Okay, now we have gonadotropin releasing hormone that will stimulate the release of FSH and LH. Okay, we are gonna, in the part of reproductive, we are gonna enter in more detail. Okay, but they simply stimulate the gonads to produce testosterone, estrogen, to facilitate spermatogenesis, oogenesis. And they are gonna produce also the hormone inhibin. Okay, notice that inhibin will make a negative feedback on FSH. And sex steroids are gonna make most of the time a negative feedback on the hypothalamus and pituitary, except during ovulation. During ovulation, these sex steroids are gonna make a positive feedback that is gonna lead to an increase, a peak in the levels of LH in the blood that will induce ovulation. Okay, now these hormones will participate in the differentiation of male, female, and will participate in the formation of the internal, external genitalia, secondary sexual characteristics, puberty, and other things.
When you said during ovulation, the sex hormone is gonna stimulate the. You said something I was writing. You said during ovulation. the
If
sex
you're
hormone-
right, you can listen. No, multitasking is not good. We can do either one thing well done or two things badly done both. I'm here cleaning the windows and the TV. Something is going to get broken. And it's going to be the most expensive. What produces ovulation? Do you really need to take notes about that? What produces ovulation?
Ovulation is the elected manifestation of the ovulation.
That go up or down?
That go up.
Ah, so that's the answer. Okay. So any questions about this part? But any special questions? Because questions, I know there are many. Here you have some resources, okay, that you can use to study comparison of the hormones, more pictures, more tables comparing things, and maybe clarifying or producing noise on other things. Some videos. Okay, and see you tomorrow. Okay.
Thank you.
Welcome.